Okay, whatever study you just did, you save it on the left panel, and the new study is on the right panel. Is that understood? Please don't do that again. Are you comfortable? Are you awake?
He wants to hear you.
Who's your favorite neurosurgeon in the whole world, Shot? Huh? Thank you. It's good to hear. Shot. All right, so what did he say? AP. So you can see the tip of the needle is in the foramen. We're approaching the herniation right now. And I want to make sure that my AP view shows my needle tip to be close to at least the mid line in the basically the center of the pedicles. If you drew a line from pedicle to pedicle, L5 to S1, we want to be pretty darn close to that, and it looks like we are. You feel anything? Lateral. Huh? He's rotated a little bit. So I'm pretty happy. I feel the herniation with the tip of the needle. I just want to make sure everything is lined up on the lateral view. Lower the fluoro. All right, that's our shot there. Are you comfortable? Shot. AP. You can feel the annular tear. It's pretty big. Are you comfortable?
Yes.
Lateral. Did you feel anything?
Did you feel anything? How about? What?
Is it where it's typical? 11.
Yes.
Well, you must have his pain under good control. All right, you can see the dye is injected into the disc, and it's leaking out through a tear in the back, and it's going up into the epidural space. I want you to count from 1 to 100 out loud by 1, starting at 1. Nice and loud. Shot. I need the table up a little bit more. A little higher. And shot. You can bring your fluoro slightly south, slightly. Like an inch at most. That's really good. Let's leave it there. Shot. Perfect. You can see the guide wire coming out anteriorly. I'm going to leave the guide wire in the disc. Shot. And I'm going to take this needle out. Blood pressure is good.
Blood pressure is on the high side.
I need you to get it down.
I'm bringing it down.
Let me know when you get it down. I can't go any further until you do. All right, do we have any questions from our audience? Our patient is asleep now. He was awake while I was placing the needle. And now he's asleep. And we're getting ready to do a Duke laser disc repair, L5S1. Everybody's in agreement, L5S1. That's the proper level, and we are on the right side, which is the side of the leg symptoms. Let me know when you have his blood pressure a little bit lower. All right, you have a question there from the audience, Zach?
I thought we did, but just 1 second.
Let me know when I can proceed. So I recommend a blood pressure somewhere around high 80s systolic to maybe the low 90s, very low 90s when you're doing this procedure, the Duke laser disc repair. And we're going to be going through the muscle. Muscle has lots of blood supply. It's highly vascular. You don't want to tear a vein or an arterial while you're going through the muscle and have the blood pressure high, because the patient will develop a hematoma within the muscle. So of course being in pain is going to raise the patient's blood pressure. So while I'm placing the needle and doing the discogram, the blood pressure will go up because of the pain that's elicited. Patient had 11 out of 10 pain at L5S1, and the heart rate will go up because of the release of catecholamines. The contractility of the heart will go up, and the patient's blood pressure will subsequently go up, plus arterial tone will increase. So you'll get a spike in blood pressure with pain, but I want that to get under control before I proceed.
We have a question.
Sure.
We have a viewer asking what the difference is between this procedure and a microdiscectomy.
All right, well, that's a good question, fair. So the patient, somebody's asking, what's the difference between Dr. Dugmage and what you're doing right now and a microdiscectomy? There's about 50 things that are different, and I'll just start with some of the more basic things. So with a microdiscectomy, which is what pretty much every other spine surgeon does, they make an incision right here in the midline. Can you see my fingers?
Yes, sir.
All right, so the patient's back is here, the middle of the back is the line, and a microdiscectomy is an incision here. So the problem with the microdiscectomy, number one, it's a much bigger incision, so more skin trauma, a larger incision to heal. Then you go down through the skin and you get to the fascia, which is the white tissue, the really thick white tissue that holds the spine and muscles together, and you got to cut through that fascia. So you're creating an injury to the fascia and a scar on the fascia. Then you got to peel the muscles off the spine and shift them over to the side. So peeling the muscles off the spine is not good either. Then you got to actually drill a hole in the bony spine to be able to go down and take the herniation out. So drilling a hole in the spine is very bad, and you got to take part of the facet joint out. The facet joint is a stabilizing joint. It holds your spine in alignment. So once you start removing one side of the facet joint, it kind of causes the spine to get unstable because you're removing the facet capsule and part of the bony facet joint. So you're creating spinal instability, which then creates back pain. It creates recurrent disc herniations, the need for fusion. You're creating a bigger scar in the skin, a bigger scar in the fascia, or a scar in the fascia. All of that's avoided through the Duke laser disc repair procedure. We're going off to the side. We're making a 7mm incision rather than a 25 millimeter incision. So our incision is 1/3 of a microdiscectomy incision. Plus, we're not going to take any bone out with this approach because we're going through a natural hole that already exists in the spine. So you don't have to take any bone out, so you're not destabilizing the spine. That's probably the most important difference with respect to the approach. Then we're actually going to enter into the disc right where the herniation is. So we're not going to damage any of the normal disc. Whereas with a microdiscectomy, a lot of times you have to take out part of the normal disc just to get to the herniation because you're too medial. A lot of these herniations are more lateral or foraminal. And then of course there's the results. With a microdiscectomy, on average you may see about anywhere between 70 to 80% relief of the leg symptoms, whereas with the Duke laser disc repair you get 95% relief of leg symptoms. And then with a microdiscectomy, it doesn't fix back pain, and it only unpinches a nerve. And pinched nerves cause leg symptoms or arm symptoms, not back pain or neck pain. So the annular debridement of the Duke laser disc repair is what gets rid of the back pain. And there is no annular debridement in a microdiscectomy. It's not done. So that's a technique that's only done in the Duke laser disc repair. And then, of course, the healing from a microdiscectomy is going to be a lot longer than the healing for a endoscopic procedure. So microdiscectomies have a complication rate of about 5 to 10%, and they include things like infection or instability or nerve damage or spinal fluid leak. Duke laser disc repair has 0 complications. 0. Does that mean we can't get a complication? Of course we can. Just like any other surgery, we can get a complication. But so far in 13 years, almost 1,000 surgeries, we've had 0 complications. So your complication rate is much lower with Duke laser disc repair, and your risk of instability is 0 with Duke laser disc repair versus microdiscectomy, which has, I think, at least 50% instability risk. And you can get the herniation out better with the lateral approach than you can with a paramedian approach with a microdiscectomy. There's really no advantage to a microdiscectomy at all. It's really a very old bad surgery compared to this endoscopic stuff. I don't even do microdiscectomies anymore. How are we doing?
Giving a lot of antihypertensive, do you still holding the 120s, 130s?
Okay. So you just let me know. I want to get him at least below 110. So what is that beeping?
That's my already going meter. That's the positive for the control.
Good. Do we have another question there, Zach?
We do. We have a viewer who says, I've had 2 surgeries, L5-S1 discectomy. My leg pain is pretty much gone, but I'm having a lot of tailbone pain. Is it possible that's caused by the surgery?
Well, great question. So we have a viewer who says, I've had 2 discectomies. The leg pain is gone, but I'm having back pain, basically. They're describing it as tailbone pain. Is that caused by the surgery? So there is no one answer I can give you because it depends on what's causing your pain. The most likely cause of your pain is the disc injury itself, and microdiscectomy doesn't fix back pain. And tailbone pain would be a form of back pain. So you can't expect a microdiscectomy to fix your back pain. That's the huge downside of the procedure, is it does not fix back pain. Now, if the surgeon removed enough of the facet joint to do the procedure, you're going to have an unstable spine. It's going to be causing horrible pain. And so that certainly is one possibility. The other is you have an infection. An infection would definitely cause tailbone pain. But that's something your surgeon would need to investigate with blood tests and diagnostic imaging, possibly a nuclear medicine study, an MRI with and without contrast, and possibly a CAT scan. So an infection is possible, depends on when the surgery was done. The more recent the surgery, the more likely the infection. Instability is certainly a concern that could be causing your symptoms. Recurrent disc herniation could also do that, where you have another disc herniation causing pain in the back, but not quite bad enough to cause leg symptoms. And it could also be that you have another cause of back pain that's just unrelated to your discs at all. It could be coccygeal ligament pain. It could be sacroiliac joint pain. It could be piriformis muscle tear with inflammation. It could be facet pain. So basically what I'm saying to you is there's no way I can diagnose what's causing your tailbone pain after your surgery you know, without actually seeing some films and doing an exam. But what I can tell you is that whatever is causing your pain is 98% curable. It's just a matter of making the right diagnosis and providing the right treatment. So if I knew exactly why you're having your pain, I could tell you exactly what treatment you need. And all those causes of pain are fixable. So it's just a matter of getting to the right place to figure out what's wrong and fix it. That being said, if you want, I'm happy to do a video conference with you. If you download the new Duke Spine Institute app, it's currently available on all Android platforms, and it will be available on Apple as well by the end of the week. And on the Duke Spine app, this is the Duke Spine Institute app, it's free. On that app, you can actually request a video conference, and you can even upload your MRI. So this is going to be the most state-of-the-art spine app in the world, and it's a Duke Spine Institute app on Android and Apple, and it was designed and created by Duke Spine Institute and our team here at Duke Spine Institute, with most of the programming done by Zach. And you'll be able to do lots of really neat stuff with the app, including upload MRI images and do video conferences. But if I could do a video conference with you and I could see exactly where your pain is, and I could see an MRI that's been done recently after your surgery, I could probably tell you what's causing your pain and what needs to be done to fix it. How are we doing? Okay, take your time. You know, let's get it right. There's no rush. It's not like I have a hot date. I'm happy to take more questions, Zach, if you've got them. Luis, have you talked to the laser people?
They're gonna send me today maybe new prices. And then
Well,
you
tell
told
them,
me that,
tell them before you do that, tell them we want to try the actual laser.
the one that actually you are gonna
Yeah, if they can put a new one here,
Yeah.
and then if we can agree on the pricing, we'll just keep it here.
I'm gonna talk to them today.
Tell them we'd like to try the laser that we're actually going to buy. If they have either a demo or a new one they can get us. So we've rented lasers for the last 13 years. Every time I do laser surgery, we bring a laser here. It's a $100,000 machine, and it's very expensive, obviously. Spine surgery is very expensive surgery. A lot of it is due to the equipment that's needed for spine surgery. The floor. Yeah. You tell me when you're ready. For example, we have a flat panel Siemens fluoro machine. It's a $200,000 fluoro machine. It's the best in the world. We also have an endoscopy tower from ConMed Linvatec. And it's the best in the world that you can buy. We have the best scopes, great, best anesthesia equipment, best laser, right? And the best people. It really takes having the best, in my opinion, and there are people who will disagree with me. Sure, you can operate on a patient with a rusty old spoon, but your results are not going to be as good as when you have the best equipment and the best medications and the best supplies. I'm a big believer in putting everything the best that you can into the surgery to get the best results. It's kind of like preparing a cake. If you use the best flour, the best sugar, the best vanilla extract, you use the best oven. I mean, gosh, ovens are important too when you're baking, right? If you have a convection oven versus a non-convection, and how that oven disperses the heat evenly throughout the chamber. I mean, if you have a hot spot, you could burn the cake on one side, right, and not cook it on the other. So I mean, the equipment is very important. You know, whether you're cooking or whether you're doing surgery, without the right equipment, you're not going to have the best results. It's something that people think that a fusion is a fusion. Doesn't matter where you go, you know, it's all the same, but it's not. It's so different, depending on where you go get it done. And they just, yeah, I wish you had made a cake for today too. But spine surgery is not like buying a car. You can't pick a make and a model in a year and expect that surgery to be consistent like a car is. If you buy a Honda Civic 2019 X model, whatever it is, it's the same wherever you go, but what surgery is not the same. And it really depends on the surgeon, the equipment they have, the facility, the staff, the medication available to them to use during surgery. And everyone assumes that it's the same, but it's 100% not the same. Let me know when you're ready.
We're ready.
You're ready?
Yes.
All right. So we shall resume. And I'm going to make my incision now. Seems like our patient is snoring happily, right?
Yes.
Snoring like a baby. So I made the skin incision 7 millimeters. Now this is what the dilator looks like. Zach, can you see this?
We see it.
You see it has a tapered tip. And I'm going to run this straight on down the guide wire. Shot. Now I did not design this system. This was designed in Germany. Shot. And engineered in Germany. But the technique of how the surgery is done is mine. Shot. It's called the Duke laser disc repair. And it's different than any other transforaminal endoscopic surgery. It's also performed in the cervical spine or the neck. Shot. But we don't come through the back of the neck, we go through the front. Man, there's a huge herniation here. I can feel it. Shot. The dilator is just kind of working its way through the annular tear. Shot. The patient described that they were at the gym lifting weights, and they felt sudden onset of pain in the back. Shot. Along with a searing type pain going down the leg. Shot. All right, we're embedded enough that I can take the guide wire out and advance the dilator with just the mallet. Shot, but I'm not happy with how far in we are. I do want to go a little bit further. That's better. All right, yeah. And I could actually feel the herniation push in. So hopefully we'll be able to fish the herniation out of the disc and not have to deal with it being in the foramen. Shot. Shot. Yeah, the dilator's advancing a little bit. I don't want that. So let's get that back a little bit. Shot. Shot. That's good. Let's get the dilator out. Again, shot. It's a little piece of disc material. I can feel it trapped between the dilator and the tube. Not a big deal. It's easy to overcome that issue. but it will advance both together, which you don't want to do. You don't want to advance the dilator any further than it is. You'd end up coming out in the pelvis, which would be bad. All right, shot. So far we've lost not even a drop of blood, for those of you paying attention. And I need the scope out, the fluoroscope out. I need the endoscope in. So not a single drop of blood. Okay? Just some redness around the skin incision, that's about it. But this endoscopic surgery is virtually bloodless surgery. So for those of you that don't want to bleed during your surgery, check out the Duke laser disc repair. Our average blood loss is about 3 milliliters of blood. Scope on. Alright, so we're inside the disc. You can see the blue. That's the herniation and annular tear. As a matter of fact, right there I think is part of the herniation. Who is that snoring? The anesthesiologist or the patient?
No, he's giving me a hard time, this guy. Making me work.
He's giving you a hard time? At least his blood pressure's good. Well, he wanted to have a sweet dream, so that's exactly what he's going to get. I wonder what he's dreaming about.
You don't know.
I think he's dreaming about facet joints. Right?
Probably.
Wedge deformities. Electrodes. What else do you think he dreams about?
The new RFA machine.
RFA machines, new ones. What about
Maybe cars.
cars? Maybe some curry laser.
Yeah.
These are all mine.
That's what I've been thinking. This curry is very resistant.
That's my favorite. I love Indian food. Okay, you want to take it through?
Yeah. Thank you.
I was in a remote little town just last weekend with Arias at a race in Newcastle, and for SCUSA, and we there was like no restaurants. There was one though, and it was Indian food, and I thought, my God, this is kind of scary, out in the middle of Indiana, and surrounded by cornfields and bean fields, and there's Gulzar's Indian restaurant. So we tried it out, and it was really, really good. The food was amazing.
Well, in Indiana was the first time I went there. I started eating Indian food.
Really?
I was in a hospital there.
In
and
Indiana?
A lot of the medical staff
Or Indian?
Indian.
Wow.
So every Friday, Physician Lounge, they would cater Indian food from a restaurant.
Huh.
And that's when I started, tasting everything. And now
Yeah, now you love it.
I love that.
So that was the first time you had Indian food, was Indiana,
In Indiana,
at the hospital.
at the hospital.
Wow. So did the cafeteria of the hospital serve Indian food regularly?
No,
It did not.
no. The physicians.
Just the physicians.
They will basically on Fridays pay for that extra.
Wow. I'm sure that I would think their wives would make the food, right? Or husbands, and bring it to the hospital. So the hotel we stayed in, I believe, was owned by an Indian couple or Indian family as well. And you could smell them cooking dinner in the hotel. It was a small hotel, but you can smell the food on every floor. It was really, really good. It smelled really nice. All the spices. So we went twice in a row to Indian food for dinner at Arias's request. Huh?
You cannot go wrong
No,
with that.
no. The kimanon was really, really good. It's hard to find good kimanon. And they had this dal makhani that was amazing. But my favorite, of course, is chicken tikka masala. You too? Is that your favorite?
It is.
All right, what nationality are you?
I'm from Ecuador.
From Ecuador?
Yes.
Oh, wow. Very cool. I was just talking about Ecuador last night online to a group of people. Well, it was the government of Ecuador that first noticed the corals dying in your ocean, in your reefs off the coast. And they hired an American marine biologist back in the 70s to come out and investigate why were the corals dying. And that's when they discovered that there was a protozoan infecting the coral, but at the time they had no idea that that was the cause. They just thought it was there cleaning up. That marine biologist did. So that's what I think of when I think of Ecuador. I've never been to Ecuador. When did you move to the States?
1990.
1990. So were you a medical student when you moved over?
I was senior year at UM.
A senior year at UM
Yeah.
in medical school.
Yeah.
What's UM?
University of Miami.
So you were a medical student in Ecuador as a first, second, and third year, and then you transferred and did your last year in medical school at the University of Miami.
Yeah.
So what's it like in Ecuador in medical school?
It was good actually. We had this agreement with the University of Miami to have the students come, and it was a good medical school, I think, because the transition wasn't difficult.
The transition wasn't difficult?
Was not.
So what is a medical school like in Ecuador? What city is it in? Are there more than one?
Yeah, there are many medical schools there, but my town is the biggest town in the country, and
What town is that?
I'm from Guayaquil.
Sorry?
Guayaquil.
Guayaquil.
How do you spell it?
Guayaquil.
Guayaquil. Interesting.
So we're in the coastal region, so we're pretty close to the ocean, and that's the biggest town, like 3 million people.
So you come from a town on the ocean with 3 million people, a city on the ocean.
It's
Did
very
you?
close. I mean, it's not by the ocean, but it's like
It's close.
35 minutes.
And your family, is it still in Ecuador?
No, my parents live in Canada, in Montreal. My siblings.
Did you play any sports when you're over there?
Yeah, of course. We love soccer.
Soccer, of course, yeah.
We love soccer.
Yes. Yeah, I want to see the patient before the patient leaves. Are they ready to go? All right, doing well, I suppose? He's been up to the bathroom and all. So our first patient's already ready to go home. We're going to go say hi. There's the tear right there.
We have a question.
You have to speak up a little bit, Zach, but I did hear you say you have a question. Go ahead.
We have a viewer asking, what is the liquid inside the tube?
What is the liquid inside the tube? Very observant. You see the air bubbles. The liquid is actually just saline. Standby laser. It's cold saline. And I mentioned it last case. It basically is refrigerated. It keeps the laser tip cool. It keeps the tissue cold. So when it leaks on my foot and soaks through my shoe, it actually freezes my toe. I feel like I'm in New York City walking around in the wintertime. Yeah. Luis is right. I need it because I fell off my bicycle and I injured my toe and it's very inflamed. So he's so thoughtful, you know, to make sure that the cold irrigation gets on my toe to keep it nice and cool. Thank you, Luis. Yeah, that's just saline, and the purpose of it is, number one, cool the laser. Number two, get rid of all the pieces of disc material that we're removing. So it kind of pulls them up to the top and out. So it clears the debris, surgical debris we call it, and it also keeps the laser cool and the tissue cool. It also helps contain the laser energy, because without it, the laser can actually shoot across the room like in Star Wars and maybe zap somebody. So by being in a liquid medium like water or saline, the laser burst is only energized for about 1 millimeter out of the tip, and it can't go shooting around in places. So I was just in Chicago 2 weeks ago with Arias to sign his very first motorsports driver representation agreement with Independent Sports and Entertainment, which is a talent agency for professional athletes. They have 300 athletes worldwide, and before we went and signed our contract with them, and he's been signed as their very first driver because they have a new motorsports program. We actually hung out a little bit around Michigan Avenue, and if you've never been to Chicago, it's an absolutely beautiful city. It's honestly one of my favorite cities in the world to visit, but not in the wintertime. Just in the summertime is good. But we went to the planetarium, and we caught I think it was an IMAX movie on space. Got to see some of the old space capsules, from the like the Atlas program, and a few of the other programs where they were launching people into space. Gemini. And it was kind of cool just kind of learning the history, because you wouldn't expect to see that in Chicago, right? Like, we're in the Space Coast. We have Kennedy Space Center 10 minutes away, but they have all these historical rockets and capsules, and just a really nice museum in Chicago. The planetarium, the Adler Planetarium, that's correct. And of course they have the aquarium there, right? And their aquarium is very nice as well. But it's also so crowded. Even if you go during the week, it's just absolutely crowded with people. But if you've never gone, it's a really good aquarium to go to. I've been there about 10 times now, because I'm an aquarium fanatic. But it's definitely worth seeing. Chicago is just, I think, a great city to visit this time of year, either the beginning or end of summer, or any time in summer.
We have a question.
7 years you lived in Chicago. Where in Chicago?
I was in the city. The last place I lived was the West Loop.
What were you doing there?
I did my training there, University of Illinois.
Anesthesia.
Anesthesia. Yeah, and after I finished, they kept me on staff there at the university, but we had contracts with hospitals in Indiana, so I was commuting from the city down to northwest Indiana.
Got it. All right, we have a question from our audience. Go ahead, Zach.
We have a viewer who says, I know everyone is different with medication. Would you have a
Sorry,
recommendation?
Zach. You have to speak up just a little bit.
We have a viewer who's saying, I know everyone is different with medication, but would you have a recommendation for nerve pain and pain? I'm on Targan 3015 and 2010 PM and PRN up to 3 endone. Not on any nerve meds, but I've been on Lyrica and
Gabapentin.
yeah, with no help and many other pain meds. Do you have any recommendations?
So I didn't hear the whole question, Zach. I heard I've got nerve pain. Do you have a recommendation for medication? I know everybody's different. I've tried Lyrica and Gabapentin, which is Neurontin. Do you have any other recommendations? Is that in essence what was asked?
Yeah, they said they're currently on Targan 3015 AM 2010 PM and
Okay.
PRN up to 3 endone.
All right, so my question is, first of all, why are you on pills for pain? Get it fixed, right? Now, you may say, well, I did have surgery and they couldn't fix it. Well, let me look at your MRI and see if it's fixable. But if you're having nerve pain, it's either a radiculopathy or a neuropathy. If it's a neuropathy, then it should be burning in your feet and numbness in your feet. But if it's a radiculopathy, it's pain that would shoot down your leg. I'm assuming you have a radiculopathy. If that's the case, that's fixable with surgery. Come get it fixed and get off the medication. That's my first piece of advice to you, and really very important to understand. On the other hand, if you say, sorry, I can't get surgery, but I need something for my pain, there are 2 medications I would consider that you haven't mentioned. One of them is called amitriptyline. Excellent medication for neuropathic pain like you're describing. It's an older medication. It was also used in the past as a mood stimulant. It's amitriptyline. The only problem is it can make you drowsy. Now, everybody doesn't get drowsy, but some people do. So you'd have to try it and see if it makes you drowsy. But 25 milligrams usually is the typical dose, maybe 50 if 25 is not enough, but you just can't let yourself get drowsy and drive. Second medication I consider is Tegretol. Tegretol, aka carbamazepine, is a medication that helps with nerve pain as well. Tegretol, Tegretol. Again, these are both not ideal treatments for pinched nerve pain or irritated nerve pain. You should get it fixed surgically with this procedure you're seeing right now. But if you don't have that as an option to get surgery, then, and you only have access to medication, then I think those would be 2 good medicines to try. Tegretol is usually, what is it, 300 or 400 milligrams per pill? Do you know? Yeah, I think it's 300 a pill. So you'd start with maybe 600 or 900 maybe, and you can go up to 1200, and usually it's 3 times a day. But talk to your doctor where you are, and you can have that a trial usually to see if it's going to work. Just be mindful that it usually takes a few days for these medicines to actually start working. So don't expect immediate relief. It usually takes, I'd say, 3 days to 5 days to actually get a therapeutic effect on your body. So don't judge them with 1 dose or 2 doses. Give them time to work. We're just about done here. Our patient is blissfully snoring. And what the patient doesn't know is that once he's awake, we'll give him about an hour to recover, and then we're going to put him back to work. Right? The patient asked me if they could go back to work in a week, and I said, you can go back to work the next day. Right? Oh, why wait a week? You can go back to work the next day.
Light duty.
Light duty. Right? Yeah.
I'm sure he can find good helpers.
I'm sure he could find good help. Well, we are just about done. You can see the epidural fat at 12 o'clock. That means that it's getting getting close to time to finish. And just above that epidural fat is going to be what's called the traversing nerve root, which in this case it would be the right S1 nerve root. And to my right at about 2 o'clock, now 3 o'clock, is going to be what's called the exiting nerve root. So you have an exiting root and a traversing root. The exiting root comes out within the foramen that I'm treating right now, and the traversing root goes down to the next neuroforamen. So this surgery that you're watching is able to decompress, standby laser, grabber. It's able to decompress both the exiting nerve root and the traversing root. And L5S1, which is the level we're doing, is really the hardest level to do. So far everything has gone well for this patient, and I expect them to do very well. Laser. But you can see, for those of you who haven't watched the surgery much, that really 95% of the surgery is done with the laser. That's a little bit of fat right there, peeking out from the epidural space. Patient's responding a little bit, probably because two reasons. Number one, a little bit light because we're getting close to the end of the case, but also we're in the most painful part of the disc, right? We've talked about this before. The inside of the disc doesn't have any nerve fibers, the outside of the disc does. So now we're right near the outside of the disc. We're actually in the outside of the disc. So this laser doesn't feel good when it zaps your nerves. And there's little nerves inside the disc. In every one of our tissues, there's little nerves. And so he's feeling the pain a little bit right now, and that's going to help wake him up, but it's also going to drive his blood pressure up. So blood pressure is looking good. And I am just putting the last final touches. I'm going to look laterally as well to make sure that there's no lateral herniation I'm missing. And that's this stuff right here. Looks good. You don't want to decompress medially and then patient wakes up and they still have leg pain. And you say, oh my gosh, I forgot to do the foraminal component, which is what I'm doing now. So you're learning all my secrets. I gotta stop teaching people so much. All right. So beautiful. You can see the end plate down there, right? The end plate is that pinkish thing right there. That's the surface of the, no, that's the surface of the L5, inferior end plate of L5. Once again, a little bit of fat, and I just want to get this last bit right here, and we're done. Oh yeah. Oh yeah. Patient is very fortunate. Everything has gone well. Hopefully it'll remain that way. Yep. God willing. So I'm going to pass him off to you, Dr. Santiago. And you make sure that he has a nice recovery.
Definitely.
Okay? And this should heal up really nicely for him. I feel like we've gotten 90% of the herniation out, and that's certainly going to decompress his root and make him feel a whole lot better. I'm going to show you the nerve root again as soon as I'm done in just about 1 minute. And that nerve root is at my 1 o'clock, 2 o'clock, now 3 o'clock. Maybe covered in fat like it usually is, in which case I'm not going to be able to show you very much. But at least you'll know where it is, and you can see that it's been decompressed. Zach, we have any more questions?
Not yet.
All right, well, this is a good time for the audience to write down any questions they may have. And I'll be over in the conference room in a few minutes and we can answer questions, okay? Just finishing up the last few seconds and we'll be done. It's just so hard to stop.
Exactly.
It's so gratifying. I think that's really good. All right. I think there's just a small little tip left and we're done. Laser off. So let's see. There's the nerve up there. And there's where the herniation was. It's gone. And we're done. And the patient wants to wake up, so. Scope off.
Lights on.
Lights on. Someone's snoring like a grizzly bear hibernating in a cave in Yosemite Park, huh? Right? All right, pressure is there. You've got this. Good job, guys. Everyone did a great job. Thank you. I'm going to head over to the conference room, and I've got a Ray Tech off the field. I'm going to go ahead and answer some more questions for our audience. Zach, I'm heading your way. Can you see if they have some fresh coffee, Zach? Maybe call Sandy over.
Yes, sir.
Is that yours? Okay, Dr. Duke Majan back with you here at Duke Spine Institute on August 20, 2019. And we just completed a Duke laser disc repair endoscopic spine surgery with a laser. And this was at L5S1. This is the bottom disc in the back. It's right where the belt is. And our patient had horrible back pain and pain shooting down the leg like an ice pick on the right side. We went on the right side and we fixed it. I expect the patient to do well. Our first patient, if you watch that surgery, is on his way home right now. Very happy. No more leg pain, no more back pain. Doing fantastic. His sister's picking him up. They're heading to the hotel. And they'll come in tomorrow for one check, and then they'll head out and fly tomorrow back to Kansas. The second patient that you just watched is not flying back to Kansas. Doesn't matter how many times he clicks his ruby shoes, right? He's sticking around in Brevard County. And I can't tell you anything more than that. I can't disclose who it is, but it's everything went perfect. Everything went really well. All right, so would you believe that I was a radio DJ in my younger years? I was. I was a DJ at UC San Diego, and I used to spin records and talk to people late at night, and eventually worked my way up into the lunchtime show at UCSD's radio station. I have an FAA broadcasting license, and used to spin the records and play music. So it seems like I'm back on that mic again now. Zach, do we have some questions? We have 3 questions. The first one, was that the inside of the disc you were removing material from? The answer is yes. That was the inside of the disc I was removing material from. So basically, as I explained earlier, either this surgery or the one before, the safest way to do this type of surgery is to go through the herniation, through the annular tear, and start at the base of the herniation and tear in the innermost part. And that way, while you're in there, you're not at risk for injuring a nerve or a blood vessel that's significant. It would be in the foramen. So you actually start within the disc. It's like starting with training wheels on every case, and then you gradually pull your way out and you remove the herniation as you come out. So that's exactly what we saw. We're inside the disc. Next question. What kind of surgery is the Duke laser disc repair? Well, it's a endoscopic surgery, meaning it's done with an endoscope. An endoscope is a scope that we put inside the human body, therefore endo. Endo means within. Scope means obviously a scope to see. So to see within the body, an endoscope. And the Duke laser disc repair is endoscopic. It's also what's called transforaminal. Trans means across or through. Foramen is the neuroforamen, so it's a transforaminal endoscopic, and then it's a disc repair because we're not actually fusing the bones and taking the disc out. We're actually repairing the disc. So imagine if you had your tire was damaged. We're repairing the tire rather than replacing it. So replacing the tire would be putting like an artificial disc. But with an artificial disc, there's lots of problems with that surgery in that you have to go through the abdomen, which is very risky of damaging the organs and stuff. It's the highest risk surgery there is on the spine in the lumbar region. And then, of course, your implant could fail. It could pop out. It could fuse anyway, despite the fact you're trying to preserve motion. So there's just a lot more risk, and the surgery is not as clean and natural as a Duke laser disc repair if you're doing an artificial disc surgery. And with the fusion, you're actually either taking the whole disc out and putting a plastic or metal spacer in there or cadaver bone in there, or you're just leaving the injured disc in. So the Duke laser disc repair is a very special surgery. It's unique in that it's the only surgery in the world where the herniation and tear are repaired by using a laser to repair it, and that allows the disc to heal itself and basically go back to its natural state after the surgery over the course of the ensuing year while the disc heals completely with collagen. It's the most natural surgery there is because there's no material put in your body. There's no bone graft. There's no fusion. There's no metal. There's no plastic. It's completely natural repair of the disc. It's honestly the most advanced spine surgery there is in the world for disc injuries. And it would be done in more locations if other surgeons knew how to do it, but they don't. Next question. What's the difference between the Duke laser disc repair and a microdiscectomy? We already answered this one, but to summarize it, the microdiscectomy, very commonly done surgery. Most surgeons know how to do a microdiscectomy. Obviously, I learned how to do it years ago. Microdiscectomy is an older type of surgery. Microdiscectomy has some really bad things about it that you really don't want as a patient. Number one, with a microdiscectomy, you have a much bigger incision. It's about 21 millimeters. Number two, with a microdiscectomy, the surgeon has to cut the fascia that attaches all the muscles to the spine. And we don't do that with the Duke laser disc repair. The incision is only 7 millimeters. We don't cut the fascia off the spine. Number three, with a microdiscectomy, the surgeon has to peel all the muscles off the bony spine. And with Duke laser disc repair, we don't peel any muscles off the spine. We just pass through the muscles gently with the dilator. Next, with a microdiscectomy, the bone has to be drilled away. And drilling the bone away to do a laminotomy or a facetectomy is really bad. It weakens your spine. The problem is that that's the collateral damage you can expect with a microdiscectomy. And that's because the surgeons around the world don't know how to do endoscopic transforaminal surgery. Otherwise, they would be doing it to avoid removing the bone from the spine and the facet joint. Microdiscectomy requires, if you read the description, it requires what's called a hemilaminotomy, which is removing the bone of your spine and weakening your spine. A partial facetectomy, which involves removing part of your facet joint. That's a facetectomy. And the facet joint is a stabilizing joint of the spine. By removing part of it, you're weakening that segment of the spine, and you're predisposing it to rotational abnormalities and kyphotic abnormalities and subsidence and just settling, which could be asymmetric, causing scoliosis, kyphosis, and also facet pain, and obviously instability with neural compression. So microdiscectomies have a lot of ugly, dirty secrets that they don't tell you about with the procedure, and the problem is that for most surgeons, that's the best they've got. So they're not going to say anything bad about the one procedure they can do to treat a herniated disc. So they're not going to talk to the patient necessarily about the ramifications of larger incision, peeling muscle and fascia off the bone, destabilizing the segment by removing bone. And then, of course, you got to pull the nerve root over severely just to get down to the herniation. So that pulling the nerve root over can cause nerve damage, spinal fluid leaks, and these are all known complications of microdiscectomy. And then on top of that, you can't really see inside the disc and do an annular debridement or repair. You actually have to just grab with those metal grabbers and hope you get a piece of herniation. You can't really see it very well. And of course, things get bloody because you don't get good blood hemostasis, whereas with the laser surgery, you saw we had no blood loss. So microdiscectomy is a bloodier surgery, higher risk of nerve damage during the procedure, spinal fluid leak, which could be devastating, instability, infection, whereas the Duke laser disc repair has none of those. And in 1,000 of the Duke laser disc repair surgeries in 13 years, we've had no spinal fluid leak, no nerve damage. The recurrent disc herniation rate with Duke laser disc repair is 1%. The recurrent disc herniation rate with microdiscectomy is, I believe, somewhere in the order of 25 to 50% of the patients have another herniation. So much better results with the Duke laser disc repair in terms of outcomes. 95% relief of leg symptoms, 95% relief of back pain. That's average for all my patients. Whereas with microdiscectomy, you can expect about 70 to 80% relief of back and leg symptoms. Depends on whose paper you read. far less efficacious and safe than the Duke laser disc repair. So there's a mountain of differences between the Duke laser disc repair endoscopic surgery you just watched and traditional microdiscectomy, and every single difference is bad for microdiscectomy, which is why we broadcast these surgeries so people can be aware of the fact that there's a much better solution for herniated disc out there in the world other than microdiscectomy. And that was our last question. So I've enjoyed our time. As I said, our first patient is leaving, and yep, we'll see you probably on Thursday if we have cases. Otherwise, it'll be next week on Tuesday. Have a great weekend and week, actually, and also remember Duke Spine Institute has launched its app, and check the app out. You can download it for Android today, and then for the iPhone by Friday. It'll be downloaded and downloadable, and it's an incredible app with lots of resources. We would love to get feedback in any way we can make the user experience better. We will try to incorporate it into the app. The app was developed here at Duke Spine Institute, so we can make modifications to it as well to make it improved. This is the first rendition of the app, so there's going to be more features that we add over time, but I think you're going to find that this first version of the app is actually quite amazing in what it can do. And aside from that, I recommend you check out Facebook, the Spine Surgery Support Group, Spine Surgery Support Group. That's Duke Spine Institute's Facebook group, where we answer questions about spine issues, diagnosis, management, surgery, anything you want to talk about related to spine. All right, so have a great day. Thanks for joining us.